Welcome to today's webinar, Improving General Practice Advanced Care Planning. Before I introduce today's speaker, I just want to go through a few housekeeping items and CFN news. Just a reminder that a Q&A will follow today's presentation, so please submit your questions online during the presentation, and we will try to answer as many as time permits. Perry Kim, our Manager of Research and IP, will be hosting today's Q&A session. A survey will pop up on your screen after the webinar, and hoping that you can take a few minutes to provide some feedback. The webinar slides for today and the video will be available within 24 to 48 hours, and you'll see the URL there. We will be revamping our website over the next little while to improve the functionality, as I know sometimes it's hard to find some of our materials. And hopefully we will improve that in the next 6 months or so. We have upcoming webinars, and hopefully everyone will register. Please register at the URL on your screen. On August 9th, we have the Innovation for Toilet Relocation and Ease Access for All Frail Elderly at Home and Wearable Caregiver Posture Coaching Feedback System. On September 13th, we have Incorporating a Frailty Dimension into Locus for Seniors in a Medical Psychiatry Population. And on Wednesday, September 27th, we have Improving Palliative Care in Long-Term Care Homes Using Participatory Action Research. We are still looking for volunteers for our board and our advisory committees, and we are really targeting citizen representatives on our committees and HQP representatives. So you can see the website if you would have a look at that and maybe apply for being part of our volunteer committee member. Just an update on our knowledge translation competition. The KT competition was designed to fund previous research. So the intent to apply was due earlier this week, and the full application is due on September 5th. We also will be launching a new competition in the next few weeks. Potentially it could go late summer, early fall, as we're working with partners to enhance this competition. And so please be on the outlook for this. We will be communicating this widely to our network and hopefully outside our network as well. So on to our webinar presentation today with our presenter, Michelle Howard. Michelle is the Assistant Professor in the Department of Family Medicine at McMaster University. She is also an Associate Member of the Department of Health Research Methods, Evidence and Impact at McMaster. And she completed her doctorate at McMaster University and her master's at the University of Toronto. Her research interests include evaluating and improving primary care models and understanding the mechanisms and impacts of interprofessional care in primary care practices. I will now turn this over to Michelle to start her presentation. Go ahead, Michelle.
Thanks, Carol. And thanks everyone for attending the webinar today. So I'm going to talk for about half an hour about the iGAP project, Improving Advanced Care Planning in General Practice. I'd like to acknowledge CFN, which was TVN when we were funded for this project as a core grant a few years ago. And I want to acknowledge all of our other investigators and collaborators that have been working on this project for the last couple of years with us. So the learning objectives of today's presentation, through the research, I hope that you will gain an understanding of how improving the quantity and quality of advanced care planning could improve healthcare for older adults, and to understand the main barriers to realizing the benefits of advanced care planning, and to understand the components of advanced care planning and how interventions to improve it are evaluated. So advanced care planning is of interest recently because of the changing way that people age and die and the amount of contact they have with the healthcare system while seriously ill, and the decisions that need to be made about approaches to treatment. So there are quite a few studies have shown that there's a frequent misalignment of patient values and preferences with the actual treatment that's either given or documented for their care in serious illness or near the end of life. In addition to that, most of the research that is coming from hospital settings right now, but in that setting, about 2/3 of seriously ill elderly hospitalized patients will not be engaged in a conversation about their treatment preferences for life-sustaining treatments. And about 1/3 will have in their records or their documentation to be signed up for more aggressive care than they actually want when someone does ask them. So it's difficult to have during an acute crisis this sort of quality conversation in this setting. In addition, we know from some research that about 1/3 of us may at some point need to have a health decision made when we're not mentally capable. And one of the solutions up until recently that has been studied quite a bit is advanced directives, which are kind of part of advanced care planning, but alone they're not the solution. So they have been a bit problematic in the clinical context because they represent treatment decisions that are made or instructions for decisions that are made out of context of the patient's current situation, made previously, that may not apply exactly to their situation when the decision is needed. So healthcare providers are typically reluctant or can sometimes be reluctant to follow those previous wishes. And we also know that the quality of some of those decisions may not be the best if the patient's values and good knowledge of the treatment implications has not been incorporated into that advanced directive, which is often the case. And we also know that patients and their substitute decision makers overestimate how well the substitute decision maker can interpret their wishes and translate those into the decisions that they would have made. So that all relates to how effective or not effective advanced directives may be. So recently, the focus of advanced care planning and the sort of end-of-life communication and decision-making has changed a bit, and there's been a new definition published through an international consensus Delphi panel, just published a couple of months ago, actually. So the new definition is, rather than focusing on the advanced directive paper or document, it's a process that supports adults at any age or stage of health in understanding and sharing their personal values, life goals, and preferences regarding future medical care. So you might notice that it's more inclusive than end-of-life decisions alone, and it doesn't refer to directives or instructions. It's anything that supports that process. And a couple of other words that came up in that definition, in that statement, that need a bit more definition and kind of underlying our research are values and preferences. So values are an expression of a person's overarching philosophies or most important priorities in life. So that might be around, for example, maximizing quality of life or having more time in life to spend with family. And preferences, when we say that, we mean really specific preferred options for a type of treatment approach. So perhaps resuscitative treatment might be one sort of preference, or preferred health states, such as the conditions that would be acceptable or unacceptable to someone as they're considering the types of their current health and the likely outcomes of various treatments. And one final piece of background that our research is grounded in is a conceptual framework for end-of-life communication and decision-making, a publication or citations down in the left corner there. But you can see that advanced care planning is really separated out from other aspects of decision-making. So much of advanced care planning happens outside the healthcare setting, not necessarily when a person is sick, although it's often not considered until around this time. So those are the conversations about values and preferences and choosing a substitute decision maker, but not necessarily making any specific decisions about treatments. And that can happen, it's never too early, but it often happens more in late life, or when a person perhaps starts to experience a condition that may be serious or life-threatening. And that's usually in community, such as family practice, or in the general public. It's a public awareness sort of issue. And then goals of care are a little bit more focused and usually come in when a person is experiencing serious illness, and it's more about their illness understanding, prognosis, goals, fears, values, and trade-offs that they may have to consider in certain treatments and health status. And then the decision-making tends to happen more about more at the end of life, and goals of care and decision making are more the kinds of things, discussions that would happen with healthcare providers who are offering various treatment options, and that tends to be in hospital settings. The goals of care discussions can happen in primary care as well. So there have been several systematic reviews showing the benefits for the processes and programs that support advanced care planning, as well as goals of care approaches and tools as well, such as conversation aids, facilitator models aimed at patients and their family members, and tools aimed at healthcare providers. They've been shown to improve several outcomes. So when advanced care planning has been done, end-of-life experiences are improved for patients and family members. There are lower rates of depression and other things, and lower rates of unwanted escalation of treatments and more hospice care. We have focused our project in primary care because of the nature of the setting and the relationships for supporting advanced care planning. So family physicians can help people with preparing for those decisions that may come later. They tend in Canada to have a longitudinal relationship with their patient or know their patient, and often also their spouse or other family members who may be involved in decisions. And we know from literature that effective strategies for integrating advanced care planning into healthcare are, they tend to have to be multimodal. They need several strategies aimed at several areas of the barriers. It's something that can happen over multiple visits, multiple conversations over time, and should be revisited. Needs time for discussion and needs to be incorporated into routines. So these concepts make it kind of primary care an ideal place to start that conversation and initiate advanced care planning. Another piece of information that we came across when determining how important it was to improve this aspect in primary care was some knowledge of just how often it's happening now as sort of a baseline. And I just picked a few countries just so you can see that there is some literature outside Canada as well. So when surveys asking patients, adult patients, how often they have talked to their healthcare provider in primary care, it's quite low, the percentages. And even the one study asking people, or looking at the last 3 months of life, had someone had a conversation, that it still was 25%. So not part of something that's routine right now in primary care, it seems. We've grounded our project in this knowledge to action framework. So we interpret knowing that there is good evidence for this activity, and yet it's not happening very much as a knowledge translation gap, really. And knowing that there are a number of tools and decision aids and things to facilitate communication out there. And we know that we need to kind of move around this knowledge translation circle to adapt the tools to the primary care setting, to understand the specific barriers and facilitators that would help to do that, so that we can remove as many of the barriers and increase as many of the facilitators as possible. So that has been the approach that's been grounding our work. So the purpose of the iGAP program of research overall is to improve the quantity and quality of advanced care planning in primary care. So the first goal that I'm going to talk to you about some methods and results today is to assess the baseline engagement and the barriers and enablers in primary care. And the second goal, which I'm also going to talk to you about, has been to evaluate advanced care planning tool efficacy and adapt for primary care setting. And then our third goal, which we're still continuing to work on, is implementing in primary care and evaluating the whole process. Our study has taken place over 3 provinces, and these are just the cities where we had participating investigators and family practices. So in our first phase of the study was an audit of advanced care planning in primary care. And we used 2 surveys. Well, the ACCEPT survey asks patients in primary care about their perspectives or engagement in advanced care planning. And we took these accept and decide surveys. They've been previously named that way and have been used in acute care, and we've adapted them for primary care. So the first part was the survey of the patients. How engaged are they? Reasons for not being engaged, who they've discussed things with. And the decide survey was for physicians, nurses, and allied health professionals. In it asked the respondents about the barriers related to their own role, the patient and the system, and their current engagement and willingness, and what would help them to do this activity more. So in the patient results, or the patient methods, we did a multi-center family practice audit of patients 50 and older who are English speaking. It was an opportunistic sampling method, patients attending for the routine office visits, and we targeted 30 to 50 patients at each family practice in 20 practices. It was a self-administered questionnaire. And then following that, within a day or a few days, we audited the chart and specifically looking just in a certain place and time frame for documentation of any prior discussions about advanced care planning that they'd had that would have been written in their charts. So overall, we had 810 responses from patients, average age about 67, fairly homogeneous ethnicity, mostly identified as Caucasian, mostly well, and 12% vulnerable or frail, and comorbidity index was quite low. So about 69% of patients had thought about the kinds of medical treatments they might want. About half had discussed their wishes with someone, and about the vast majority, it was family members, 23% a lawyer, and 18% their physician. About a third have written down some of their wishes in some sort of documentation. We didn't ask about any specific forms or anything. About half said they had named someone to be their substitute decision maker. And those are sort of the four main components of doing advanced care planning. And 23% had engaged in all four of those, and 19% had engaged in none of those four behaviors. And then when we followed up with those patient charts, looking in the places where the practices told us something might be documented, if anything, there was a mention of the words that might indicate this sort of discussion had taken place at some point in 4.7% of charts. So then for our healthcare provider survey, this was also a multi-site survey of our participating practices, as well as we went to other venues and organizations to try to recruit some more healthcare providers to complete the survey, and it was aimed at physicians, nurses, and other allied health professionals. It was an e-survey, self-administered, and asked about those barriers in those categories. And we generated this questionnaire from the literature and from the past one in acute care and through some primary care focus groups. And we've actually done a bit of validation work on this survey with some factor analysis to show that the internal consistency of those three constructs was fairly good and explained a reasonable amount of variance. So we had 186 healthcare providers answer the survey in total. A few more physicians than other health professionals. In the 40s, the average age range, mostly female for the allied health professionals and about half female for physicians. Around 15 to 18 years in practice, and about half rated learning about advanced care planning as a high skill priority, or high priority for learning that skill, and about 20% had reported they had some sort of extra training in palliative care. So these next few graphs will all look, are basically laid out the same way. So these are answers to the questions on the scale of, on the bottom, and each of the questions there. And the red D is the mean for the physicians and their response. The blue O is the other health professionals, and the triangle is the overall average. So just the thing to note here, these are the possible sorts of activities that healthcare providers could be doing with their patients. Most of the activities are in terms of what people are doing now. Currently in their behavior around advanced care planning was quite low, so they're not doing this very often. And the question of how willing would people be to do advanced care planning activities with patients was more to the other end. There's a fairly high willingness of both physicians and other healthcare professionals. And in primary care, where there often are other health professionals in some of the team models, this is perhaps a way to overcome some of the barriers and to help leverage those professionals with their skills. The barriers part of the questionnaire, there were actually 31 of them altogether. I'm just showing the top 10 for you here. So not at all to an extreme amount. And you might notice right away that they're all below 4 mainly. So nothing was really, even the top 10 were not rated as very large barriers. Mostly they were the same for physicians and the other health professionals. So then the barriers that start with number 3 are the system-related barriers, and the barriers that start with a 2 are related to patients, and barriers that start with 1 were related to the healthcare provider themselves, but none of those came up in the top 10. So insufficient time being the top one, and close to it, the inability to transfer the patient's advanced care plan in the system, or it doesn't really go anywhere from primary care records to other systems, just doesn't really happen. There were some other barriers relating to the system in terms of the last one, for example, that people felt their patients were getting different messages from the family doctor and other specialists that they might be involved with. And for patients, the theme generally was about their preparedness. So the results also suggest that people were thinking about this advanced care planning activities or conversations they might have. It seemed as quite late or quite end of life related when they're talking about people being involvement of other specialists with perhaps serious illness. But certainly quite a number of things came up that related to the ability of the patient or readiness of the patient to engage in conversations as well. And we sort of qualitatively analyzed the open-ended question about what people felt would help, and this was quite informative too. So the themes that came up were 1, public engagement, so perhaps more media attention, people knowing that advanced care planning is for everyone, not just for the very ill or elderly. Healthcare provider attitudes, this person pointed out that patients don't seem to be getting the message from elsewhere in the healthcare system about the potential benefits or not of medical care at the end of life, and they worry they sound like conspiracy theorists when they are the only one telling their patients this. Training, people ask for training, and that they weren't engaging because they didn't have training for these specific discussions. Integration into workflow, so tools and processes. So people were asking about a way to put triggers and documents in the EMR that would remind them, making it part of something routine like a physical that could trigger, again, a time when it would just become a part of normal routine activities, and having educational materials that patients could review and look at before even coming in to discuss. And system and policy support, so relating to the time needs remuneration. It wouldn't be seen as a priority unless there was some payment for physicians. And currently there is not much in the way of billing codes and things for the specific activity. So the second part of our study, so after taking a look at those barriers and what people suggested would help, we have really focused our work now in the next phase on evaluating the tool efficacy and adapting them for the primary care setting, and I'll explain what we mean by evaluating and what we mean by tools. Another area of work that has influenced our thinking is around decision aids and the decision theory behind it. So even though advanced care planning isn't a specific single decision, aspects of it can help us prepare people the best way for those decisions. So structured interventions and decision aids have been recommended, and that's because if they're designed well, then they should support the alignment of decisions with values and preferences. So recent literature shows that values and preferences are not very well formed when patients arrive, for example, at the hospital. This recent study that came out looking at the consistency of values and preferences found that often people indicated that their values were for the longest life possible, but also for the most comfort and the least machines. So there's really highlights a need for more education and earlier discussions about what some of these decisions might be about. And it also reinforces those primary care clinicians' perception of patients not being really prepared adequately. We also are interested in enabling patients in this project because patient activation strategies in general can be very effective, and we think that's a great strategy for primary care. So in terms of the tools that I'm going to tell you about, they're basically resources, educational resources that provide information about advanced care planning, encourage action. They help clarify values, elicit wishes and preferences. And there are a number of them publicly available, and some specifically for Canada in specific provinces. These are just a couple of examples of what they look like. The Prepare tool on the left is a tool that takes people through the steps. It's a US tool, and it also shows people how to have certain conversations. So it has a lot of how-to steps in it. On the right is the fairly new Ontario Speak Up workbook, and across Canada we have the Advanced Care Planning in Canada Speak Up initiative, and there are province-specific tools as well, and one for Ontario. And it also shows the person going the steps, and there are some interactive parts about questions and answers and education for them there. So why would we want to evaluate these tools to see if we could put them into practice? There was a systematic review done a couple of years ago that pooled together all these sorts of decision aids and looked at what was in them and how they'd been evaluated. Many have not been evaluated at all or rigorously. And they're all quite variable and various reading levels and grade levels. And so they do suggest that they need to be validated to be accessible, readable, understandable, and appropriate for various settings. And of course, we also want to know whether they actually do engage people and help them with this process, so the impacts. So the outcome that we focused in this phase of our study of evaluating tools was it's a survey called ACP Engagement, and it's not only about has someone made a document or an advance directive, which we've moved away from, but it's a survey that is based on stages of behavior change, and it comes out with a number of sub-scores and total scores. And generally there are processes that prepare people for action, like knowledge, contemplation, self-efficacy, and readiness. And those questions are asked and can be averaged together for an overall score on the processes. And then there are actions in terms of what people have actually done. And across all these domains of advanced care planning behaviors, there are things that people could do in terms of making decisions, talking to people, doing certain papers if that's relevant to them. So the version we worked with is a 55-item survey, and we got the two scores from it. And since the time that we started working with it, there have been published much shorter versions as well that have good psychometric properties, so much more amenable to research. So what we did in this phase of the study was it was a prospective small studies of evaluation of advanced care planning tools in primary care patients. So we would enroll patients and prescribe them to use the tool at home. And we did approximately 30 to 40 patients enrolled per tool. We were using different things across different provinces. Our research assistants checked in after a couple of weeks to see if people had started to engage with the tool, or if they just need a little bit of prompting or coaching, or if they had, then they would just book the follow-up evaluation. But we allowed about six or so weeks for people to engage with the tool and then do this post-survey. So the survey was done at baseline and after 6 weeks. So in this study sample, on average, patients were 69 years old. Again, they were recruited from family practices. A little more female, about 70% female, and again, fairly homogeneous Caucasian population. So this graph shows the pre and post scores of that ACP process score, and across the bottom are all the different studies of the different tools that we did. So one patient would only be in one of these groups. So generally, the take-home point is that they all did improve engagement in those processes overall significantly. And we haven't analyzed in granular detail all of the subscales for all of the tools yet, but a couple of them we have. So you can just see where some of the differences might be in, it looks like a bit that knowledge and self-efficacy were the things that improved a little bit more. People seem to have a fairly high level of confidence already. And then in terms of the action scores, there were a possible 21 actions, and this is the count of how many people had done before and after. A few of them were statistically significant, but not as much change in the actions, and there's still a way to go in terms of achieving all of those actions. Interesting, I just want to show you a typical results pattern about how this survey really works and the kind of results we could expect from the tools. So on the left is a typical tool results pattern where of the processes. So the knowledge, contemplation, self-efficacy, and readiness, and the red is the mean from pre to post, and the blue lines are all the individual scores. So you can see a trend that generally most people are kind of increasing their engagement from pre to post. And then the actions and the behaviors on the right is a little bit different. So a fairly small overall mean increase, but you can see why that might be, because many people actually in the post had realized they maybe hadn't done things as thoroughly as they had thought, and some of the scores actually came down. So perhaps longer, this was just a one-time kind of pragmatic intervention of giving people the tools to work on their own. So perhaps a future follow-up, or as time progresses or people move forward, if they did develop an illness, that might be when we start to see the actions start to rise, but certainly seem to be having impacts on people's knowledge, understanding, and readiness to do these things. So our conclusions from that phase of the study were that there's probably a place for all of these tools. They all seem to work fairly similar in terms of engaging or increasing engagement in those processes, average 18%, mostly in knowledge and contemplation. There were increases in the actions, but in this kind of time frame in this population, they still remained fairly low. But generally, we think that the tools to increase patient engagement have the potential to work in clinical environments, so family practices could work with these tools with patients to get them engaged and activated. So this is my last slide. This is kind of where we ended up with this project, and there are some other projects still that we're still working on in this research program. So the next thing that we're working on is to optimize the use of the tools in primary care patients, and especially for increasing the substitute decision maker engagement and outcomes of value concordant informed preferences. So we've got an additional values clarification tool to help with some of that process, and we're doing an RCT in Alberta and Ontario coming up of doing that sort of pathway approach with patients one-on-one in a bit more of a intensive way in some trials. This work has also allowed us to move towards the next CFN-funded cross-sector project. So we've been recently funded with others in acute care and long-term care to look at overall how to use these tools to improve advanced care planning and goals of care discussions across all these settings, to optimize the use of these tools and approaches in the clinical workflows in each of those settings, with some common outcome measures and focusing on frail elderly patients. This work has also allowed us to collaborate to help move ahead the science in this area. So collaborating across sectors to be awarded the new CFN grant, and also with some of the networks that we've aligned with, the CareNet. We've used their framework on end-of-life communication and decision-making and contributed to that. And also a number of us have contributed to that consensus definition panel for the new definition of advanced care planning. So we've been able to foster a lot of international collaborations as well and help to move the science forward.
Okay.
end of my presentation. I think happy to take questions. I think we have a bit of time.
Yes, thank you, Michelle. And that's a very informative presentation and very interesting, as I see we still have some work to do in this area. So yes, I just want to remind everyone to please send in your questions, as Perry will be starting the Q&A portion of our webinar right now, I guess. Over to you, Perry.
For questions to come in. I've got some questions of my own I'd like to start off with, if that's okay, Michelle.
Sure.
So one of the questions I had was that just looking at the results of your study, it seems like a small percentage of physicians or allied healthcare professionals had discussions with their patients with respect to ACP and so forth. I was curious in terms of not necessarily the percentage of discussions, but how long those discussions were in sort of the average time frame, and whether that was, in your opinion, appropriate, or they should be, or whether they're appropriate and achieve the goals that the allied care professional might want to achieve.
Actually, we didn't ask that question. That would have been that would have been a good question in terms of time being a big barrier. But I think it's time in kind of the typical 10-15 minute clinical consultation in family practice is what people were gauging it against, and feeling that it would take much more time than that. Anecdotally, family doctors have indicated that depending on how ready and knowledgeable the patient is, it could take a really long time, like 30 minutes maybe, even just to get things started, and it may not be a one-time conversation. So
Right.
That's why it's really important to have some of those tools given to patients that are designed to engage them and give them some earlier knowledge so they can be best prepared. And often nurses and allied health professionals, they're scheduled a little bit differently in primary care. They do more chronic disease management, and so their way of practicing and organizing their visits may be more amenable to longer visits as well.
Right, thank you. The reason I ask is that I noticed that one of the comments from your study was that there wasn't either enough time to have these sorts of discussions, or the incentives weren't there to sort of compel some of these allied healthcare professionals to have these conversations. I'm sure you've given this a lot of thought, but how do you think we could address those sort of major barriers or challenges?
I think it does need, I think that financial incentives, they may not solve all of those problems of time and things, but I think they can solve some, because if there is a financial incentive, it makes it seem more serious, like more important. I think there might be an importance attached to that. In terms of the other barriers, I think it's like any change. It needs some change. It would need some change management and a bit of an intentional restructuring of things to fit it into routines. So a reliable trigger that maybe pops up in the EMR, a selection of the sort of patients that might most benefit, and then some sort of program or way of approaching something. Like there are probably parallel ways in family practices of how certain things are approached. So I think it's just the practices coming up with approaches and tools that they can have at their fingertips.
Right. Thank you. We've got a question here, Michelle. A straightforward question. Did one of the assessed decision-making tools stand out as better than the others?
No, I don't think they did. They are developed a little bit differently in terms of the emphasis of what's included in them. So the Prepare tool, for example, it was all done at a grade 5 language reading level, whereas many of the other tools are not. It was done intentionally in the U.S. to represent certain ethnic groups, and it was done intentionally with stages of behavior change presented in a way that should facilitate moving to action, which I think most of the other tools haven't been, but or maybe they include that information, but they maybe haven't been developed as intentionally that way. But the Speak Up tools were also a really good suite of tools because they include the relevant information that people want about their jurisdiction in terms of perhaps legal frameworks and who should be a substitute decision maker. So it really does, those were also based on lots of patient feedback and citizen feedback about what people really want in those tools. Because it's mainly paper, there are just now starting to be some online versions in the last couple of years, but the online tools have the opportunity to be a little bit fancier and interactive, and people can answer questions and multiple choice things, and they can get information back about themselves and things like that. So those are appealing to some people that want to use computers, but I think they all have a place and some strengths, and but where people probably need a bit more help is in figuring out how their values and preferences may relate to decisions in the future, and that can come into some of the conversations in the healthcare setting.
Right, thank you. We have a question here. Wondering about research on ACP discussions with patients from other cultures. Navigating through established values, beliefs, and Canadian health system is still a challenge. Any suggestions or approaches?
Yeah, that's a good question. We're starting to embark on that in our next project in terms of making sure that, or identifying some of the major groups that may have difficulty accessing and seeing how amenable some of the current tools and approaches are to various groups that may have different ways of looking at this. Some of the Speak Up tools, Canadian tools, are translated and culturally translated as well. So those are some options that are currently available, but that will be part of our next research as well to kind of delve a bit more into how appropriate some of the tools are and what modifications might be needed for certain populations.
Fair enough. Next question. Is there an example of a region in Canada in which ACPs can be retrieved from the EMR across care settings? So I guess this goes to sort of, even if you have an ACP, advanced care directives, oftentimes, at least in the past, is it readily accessible by the healthcare professional at the time of, when a decision needs to be made and so forth?
Right. It's starting to happen. I guess Alberta may be the furthest ahead, and their organization or the research team called ACP CRIO, CRIO, they would have much more up-to-date details on all their system advancements and things, but they do have a standard form that is starting to move through the system. Exactly where it goes to, I probably couldn't say accurately at this point because I think it's a bit of a changing landscape. So I guess the answer probably is it's starting to happen in Alberta and BC more so, but stay tuned exactly where. I don't think that there's any province right now that has it going from primary care to following the person around wherever else they may be in the healthcare system. But it's starting to happen in pieces in BC and Alberta. Yeah.
Well, that's good to hear. Got a question here about substitute decision makers. As an ACP educator, a number of people have said they worry about their chosen substitute decision honoring their preferences, even though they have deliberated about choosing their substitute decision maker. Have you heard of this concern?
I have anecdotally heard about that. Yeah. I guess again depends what province someone is in, whether what the legal standing of the standalone advance directive might have versus substitute decision makers. Yeah, that's a tough one, and maybe I don't know. Maybe one aspect of that is how much they really have the children or the family really understands or how well they've communicated about where some of those wishes are coming from or why the person has those wishes. Yeah, so not an easy answer, except for probably more conversations, and there are some really focusing on maybe some of the values clarification type questions and prompts in some of the tools.
Yeah, I'm just curious as a follow-on question. In terms of that subject, and those sorts of issues, is there sort of evidence to show that patients who have close family members are married, i.e. have a spouse and children, they have less problems choosing a substitute decision maker as opposed to those that may not have the support system and therefore may choose a substitute decision maker that may be a friend and maybe even a close friend, but certainly not someone that lives with them and certainly understands them in that intimate manner?
Oh, that's a really interesting question. I don't know if I'm not aware of evidence about whether the substitute decision making fulfilling that role works better depending on whether it's family or not. I'm not aware of the evidence. Yeah.
Okay, just a thought that crossed my mind. We've got a few additional questions I think we could cover before the end of the hour. This question is, this individual is curious to know if you've decided which clinical provider tools you will look at for your next CFM project. I imagine that's your transformative grant.
Right. Yeah, I think that in some way, in variation, I think what all of the sectors are going to be looking at is a conversation guide for providers called the Serious Illness Conversation Guide. It's becoming quite well known in Canada. It's from the U.S. Out of Harvard, but it's becoming quite popular and talked about in Canada and being used already in clinician education. So they have an annual program where you can go and sign up for training and be the trainer person for your organization, and it's quite evidence-based. So that is something that we would probably be looking at. And it works. I think it's appealing because people can use it in all different settings. It was tested initially for outpatient cancer settings, and it's going to be modified for acute care. It's very appealing to primary care providers. They've got a great training program and community of practice for learning how to use it. So I think that's probably something that will be one of our main tools going forward.
Oh, that's good to hear. I'm curious, I thought I saw in one of your slides that I thought it said 20%, at least of the healthcare professionals you looked at had some sort of certification or training in this area. Is that still the case? And is there a movement to increase that at the medical school level and so forth?
Yeah, our question wasn't too specific. It was just to get a bit of a sense, and training could be any kind. We kind of left it open for any kind of training, which would be very different from certification. So I expect that most of those people, it might have been just some additional training or CME. The medical schools for palliative, well, I don't know exactly where the schools are at, to be honest. I may not be the best person to answer. I know it's getting lots more attention, palliative care, and these sorts of conversations as part of training. We're getting a lot of interest from students especially, and from educators about this issue. Yeah. Yeah,
it seems like an important topic, certainly, to train the next generation of professionals. Mm-hmm. So they're related to all of the above that we just discussed. There's a question here. Do you have any suggestions for allied health professionals to help with ACP discussions and process? I think you mentioned some tools and so forth.
Yeah, I guess in primary care, there were a few other survey questions that I didn't get into, but some of the things that the allied health were suggesting, they had a bit more concern in the level of how they rated the barrier of not enough knowledge or education. It wasn't in the top 10, but that was higher than for physicians. So it suggests that some additional training would be great, maybe around that serious illness conversation program and getting familiar with things like the Speak Up tools. And I think another thing that came up for them was clarifying, well, if they're part of a family practice, clarifying their role in that. So they would want to know with the physician, how are they going to approach that conversation with patients, and what's their role, when does a physician need to be involved. But we think that there is a great opportunity, and many of the practices that we even talk about in participating in the research, they're enthusiastic because they see a role for their allied health professionals to be involved. But I think it's important to clarify what that role is so everyone knows and everyone's comfortable.
Thank you, Michelle. I think we're just starting to run out of time. So I really thank you today for sharing your research and for answering all these questions. I think there's maybe one or two additional questions which we may forward to you directly. Thanks everyone for coming on today. And I see that there's still a few questions, and I'll remind everybody that this presentation will be up on our website within 24 to 48 hours, as a few people joined us later and were interested in hearing the beginning of this presentation. So I'm hoping to see everyone at our next webinar on August 9th, and that will conclude today's webinar. So I'm hoping everyone has a great rest of the day. And again, thanks, Michelle, and thanks for everyone tuning in. Bye-bye.